Hey NCS podcast listeners, this is your host Fawaz Al-Mufti. Welcome to another episode of the Neurocritical Care Society podcast's Newsflash, New Science in Neurocritical Care. We're excited to announce that for the first time we'll be podcasting directly from the NCS annual meeting in beautiful Vancouver, British Columbia, highlight from hashtag NCS 2019. We hope you enjoyed this episode.
Well, hello everyone. Welcome back to the Neurocritical Care Society podcast. I'm Ramani Balu. Our episode today is being recorded at the annual Neurocritical Care Society meeting in Vancouver, British Columbia, and it is an honor to have Dr. Benjamin Abella as my guest on the podcast. Dr. Abella is a professor of emergency medicine at the University of Pennsylvania and director of the Penn Center for Resuscitation Science. He's a world expert on many aspects of cardiac arrest care, running the gamut from pre-hospital resuscitation all the way to targeted temperature management and post-arrest neuroprognostication. He's also the medical director of the Mobile CPR Project, which is a nonprofit organization that provides free CPR training and outreach to the Philadelphia community, as well as the founder of the Penn TTM Academy, a continuing medical education platform that provides online training resources as well as live courses centered around post-cardiac arrest care. It's safe to say that I have never met anyone who is as passionate about improving the survival and outcomes of patients that have suffered a sudden cardiac arrest. Ben, welcome to the Neurocritical Care Society podcast.
Thank you, Ram, and thank you for that lovely introduction. And I'm thrilled to be at my first Neurocritical Care Society meeting.
So you're a newbie.
I am indeed a newbie, and it's been a great meeting. Very impressed by the energy in the group, the enthusiasm for the advances in neurocritical care. It's been a very great experience.
That's great. So before we start, I also wanted to just mention that the Penn TTM Academy has its own podcast series that covers a lot of topics of potential interest to the neurocritical care community, including, but not limited to, in-depth discussions of recently published clinical trials.
Thank you for that. That's true.
So let's get right into it. I would say the neurocritical care community is well aware that sudden cardiac arrest is a major cause of mortality and morbidity worldwide, and that the primary driver of outcome in these patients is the degree of hypoxic ischemic brain injury. Neurointensivists are often called on to provide an estimate of the capacity for meaningful recovery in comatose survivors of cardiac arrest, but I suspect that in general we are less involved with the immediate ICU management of post-arrest survivors, since these patients are usually cared for in medical or cardiac intensive care units. So with that in mind, I wanted to pick your brain on 5 of the most common issues that come up during post-cardiac arrest care.
Sounds like an excellent agenda.
All right, so let's get right into it. The first thing centers on targeted temperature management. So after the publication of the TTM trial, which showed that there was no difference in outcome in comatose survivors of out-of-hospital cardiac arrest that were treated with TTM either at a dose of 33 degrees or 36 degrees Celsius, I hear a lot of intensivists say things like therapeutic hypothermia doesn't work. So when caring for a post-arrest patient, number 1, is TTM needed? And if so, what target temperature should we use?
The confusion has indeed been broad regarding both the timing, dosing, and whether to institute TTM at all following cardiac arrest. So I agree with the premise of your question very much. Some of this confusion comes from the fact that there have been several recent trials that have called into question the right dose of target temperature management. That is to say, the right target temperature and also the right duration. And although they have not at any level said that TTM doesn't work, anytime you introduce complexity or confusion, it throws everybody off their game, as it were. So to answer your first question first, TTM is definitely helpful, and I would go as far as to say required for most patients following resuscitation from cardiac arrest. And this is supported by international guidelines, so I'm not saying anything overly provocative. The American Heart Association and the International Liaison Committee on Resuscitation, 2 of the bodies that have been very involved internationally around guidelines for post-arrest care, both strongly recommend the institution of targeted temperature management following resuscitation from cardiac arrest for those patients who are not waking up. And so that means different things to different people. As best it has been defined operationally, a Glasgow motor score that is not 6. So if people cannot follow motor commands volitionally, they need TTM. And the evidence is fairly clear on this from a number of randomized trials. Now, as far as the dose of temperature, most hospitals that have protocols for TTM will manage patients at 33 degrees Celsius. 33 was the general target temperature in 2 randomized trials that were foundational in this whole field in 2002. And a number of observational studies have found that 33 degrees provides enormous benefit for both survival and also for neurologic recovery. Now, the TTM trial from Nicholas Nielsen and colleagues in 2013 in New England Journal of Medicine was one of the sources for some confusion in this area. They did a dose-finding trial where they looked at 33 Celsius and 36 Celsius as target temperatures and found no difference in outcomes. So some hospitals have indeed switched to 36. It's important to note, though, that just the last year or two, there have been 2 studies and one currently in press that have shown that when hospitals switched to 36 as a practical matter, that is, they changed their protocols, their outcomes worsened, and they're now switching back to 33. So there's clearly a bit of a disconnect between results from a very well-controlled, well-performed clinical trial and real-world application. I could go on for quite a while on this, but suffice it to say that yes, TTM is required, and we generally recommend 33 as the target temperature for most patients following cardiac arrest.
And just to clarify, the reason why, in light of the results of the TTM trial, that you would advocate for 33 degrees is more because in these real-world studies that are coming out, when people implement a 36-degree temperature strategy, it seems as though fever control is actually not as good, and patients may not actually have as good an outcome because in the real world, we're just not as good as the tight temperature management that occurs in the auspices of a randomized controlled trial.
Yes, I think that's right. So managing temperature at 36 in the real world, it's closer to the fever threshold. More patients get fever. We know that fevers are very bad for the injured brain. And I think there's another really important point that is not discussed enough with regard to dose. The adverse effects of temperature management at 33 and 36 were indistinguishable in the TTM trial and the subsequent Hyperion trial that just came out in the New England Journal of Medicine, where 33 was compared to 37. Now, why do I bring this up? For those who would suggest that 36 or 37 or some higher temperature is reasonable as fever avoidance, I would ask, what are you trying to save? What benefit is to be gained by managing patients at 36? If the adverse effects are the same in both arms of the study, and this was clearly shown in the TTM trial, then why not be aggressive? 33 is the more aggressive care. We know that brain injury is significant in these patients, and the time to manage it is in the acute phase. So I think intuitively to people, 36 or 37 sounds quote-unquote milder, but indeed that's not what the data show. There's not much benefit to be had from reduction of harm.
Right. I think that's an important thing that sometimes gets lost in the discussion, that things like the dose of sedative or the dose of paralytics isn't really different when you're thinking about 33 degrees versus 36. So a slightly related question, which might be a moot point if we're all going to move towards 33 degrees, but I've heard it asked a couple of times. So patient comes in, their core body temperature is 34.5 degrees, and you're at a shop that is using 36 degrees. What do you do in that patient's case? Do you warm them up to 36 degrees because you're in a place that thinks that 36 is the same as 33? Do you keep them at that same temperature, or do you cool them down?
Yeah, that's a great question, and it does come up a lot because most patients upon arrival after field resuscitation from cardiac arrest, they're not at 36 or 37. They tend to be more in the 35 to 36 range, sometimes even lower. And so it feels wrong to me, knowing about the mechanisms of brain injury that are at play, that you should warm these patients. So if someone comes in at 34.5, the thought that you would turn on the burners and heat them to 36 in the middle of ongoing brain injury seems illogical. And so now at our shop, we manage patients at 33, and so this wouldn't be an issue. We will cool those patients. But if you're at a hospital that manages at 36, what I'm about to say is my opinion. This is not based on any studies. I would recommend holding them at whatever temperature they're at if they come in under 36. So if they come in at 34.5, 35, 33.7, I would say if you don't believe in 33, fine, but don't warm them. Keep them where they're at. Now, important to note, there's no trial evidence supporting that theory, but we know that the brain is very injured in the first 24 to 48 hours, and we know that heating them may worsen a number of things as far as inflammatory mediators and post-resuscitation outcomes. So I think you should hold the temperature or cool to 33.
Great. So here's the second question that comes up. A common cause of sudden cardiac arrest is acute myocardial infarction, but cardiac arrest can be caused by many other factors. So who goes to the Cath Lab, and how quickly should they go?
The question of who goes to the Cath Lab has been around for some time in this field, and you can imagine there's a dynamic tension between emergency care providers like myself and interventional cardiologists. It would be important for your listener group who are neurologists to know that there's enormous pressure on cardiologists from public reporting of outcomes from cardiac catheterization to not take patients who are destined to die to the Cath Lab. It can impact them financially. It can impact them in other ways. And this is an unfortunate unintended consequence of public reporting of cath outcomes, is that cardiologists often feel some pressure, sometimes subtle, sometimes not so subtle, to cherry pick and not take tremendously ill patients to the Cath Lab. Heroism is not being rewarded in this current culture. And so some states have an exclusion for cardiac arrest, so they're not counted against cardiologists, but many states like Pennsylvania do not have that exclusion. And so when I call a cardiologist at 2 a.m. and say, gosh, I think this post-arrest patient needs a cath, they had VFib arrest, they have a history of coronary disease, and their spouse was saying they were having chest pain, well, if it's not a STEMI and the troponin is negative, that cardiologist may be very reluctant to take them to the lab. But the question remains, who should go to the lab? We know that a large fraction of people with out-of-hospital cardiac arrest have significant coronary disease. We know that improved coronary blood flow is good for the critically ill patient who has a lack of coronary blood flow. So it seems that a number of these patients do need cath consideration. The one group that is clear, if you have a STEMI on post-arrest EKG, that is to say you have electrical evidence of a ST segment elevation myocardial infarction, you should go to the lab. Thankfully, that's not something that is a source of disagreement. The American College of Cardiology and the American Heart Association have guidelines that clearly give a Class 1 recommendation to going to the lab for STEMI with or without cardiac arrest. So that's the easy group. The less easy group are the ones with EKG changes or troponin elevations. That is to say, higher risk for thinking that they have coronary disease, but they do not have STEMI, and that's the group we really struggle with. An important trial came out very recently called the COACT trial, published in 2019 in New England Journal of Medicine, that didn't answer the question of going to the lab or not, but asked the question of if you're going to cath, should you cath early or late? And they found that delayed angiography was equally beneficial to immediate angiography. Now, you can imagine this made cardiologists rejoice around the world. It means you don't have to get out of bed at 2 a.m. You can wait a few days. However, I would caution people to not overinterpret this study. The vast majority of patients in this study performed in the Netherlands ended up on cath not having significant coronary disease or at the very least not having acute thrombotic lesions that needed PCI. Most patients did not even receive angioplasty. They only received iodinated dye and an angiogram. And iodine does not improve outcomes from cardiac arrest. A balloon might if you have a blockage. And so I don't know why this was the case. Is it because the Netherlands is just that good at medical therapy of coronary disease? Is it just something about their patient cohort? But this is not what we see in the United States. And so I think the question still remains for select high-risk patients, history of coronary disease, chest pain the day of arrest, no other cause of arrest, these sorts of things, should they go to the lab? And as you can tell, I tend to be a proponent that they should at least be aggressively considered for the lab. Now, whether that takes place right away or delayed is also still a question that I think the COACT trial doesn't fully answer, but it does suggest there's some flexibility there. So the way I try to make this simple for everyone, I think every post-arrest care TTM protocol should at the very least have a checkbox that cath was considered. And if cath is not going to be done, there has to be an explanation of why that goes in the chart. If you don't decide to cath a patient, that's fine. But I think we need to go through this mental exercise for every out-of-hospital cardiac arrest patient by routine. Should this patient go to the lab? If not, why not? And I think through doing that, we will think about it more, we will be more thoughtful, and we will engage cardiology in a more meaningful way for these patients.
Is there any evidence that going to the Cath Lab impacts neurologic outcome, either by making neurologic outcome worse because you might interrupt targeted temperature management, or maybe improving neurologic outcome because you're doing an intervention that may support heart function, which can support global perfusion?
Those are great questions. There's no randomized trial evidence about that. What I can say is there is a large body of literature, observational studies of people who go to the Cath Lab post-arrest, and in general, in aggregate, neurologic and survival outcomes are better. So at least it doesn't demonstrate that there's a big negative impact of going to the Cath Lab at some point during this process. And indeed, it can be coordinated very well. It needs more study, clearly. And I think what we really need to do is try to figure out how to risk stratify these patients, how to find the patients who are at high risk based on clinical factors. Because the COAC trial took all patients with shockable out-of-hospital witness arrest. They did not select for patients who had a high probability based on a variety of factors that are knowable, whether they might deserve angiography.
Great. Okay, so here's question number 3. We have a patient that comes in with an out-of-hospital VFib arrest. We've managed them. That patient has woken up. They're going to do well. They're going to rehab. Does that patient need to get referred for a defibrillator?
So the question of whether a patient needs an ICD, by defibrillator you mean an implantable defibrillator, is an important one. The general consensus is that patients who have a shockable rhythm arrest and on subsequent angiography are found to not have coronary disease, they all need ICDs. Now, whether they need the ICD immediately or they can wait remains an interesting question. In general, we feel it should be placed sooner rather than later. After all, they had an arrest. This isn't a situation, for example, of non-ischemic VT where they didn't arrest and maybe they can schedule an ICD placement. So if a patient is not well enough to receive an ICD during the hospital, there's an option now, sort of a bridge, if you will, of something called Life Vest. I'm not here to sell you that therapy, but patients can go with a wearable defibrillator and then get the ICD placed later. I think it's important that these patients get protection one way or the other, because if they have clean coronaries and they had a VFib arrest, they're at high risk of having another one. And indeed, I've met many survivors who had many subsequent rearrests in the days following arrest in these sort of settings. Now, the other interesting question would be, what about patients with VF who have coronary disease that may or may not have been revascularized? That's a more open question. I do think that all patients who have shockable rhythm arrests need an electrophysiology consult before they go home. So an electrophysiologist can weigh in one way or the other. I think the mistake often gets made, especially if patients end up not on a cardiology service, a neurology, internal medicine. Sometimes they go down a path where they don't think about that EP question. They're thinking about rehab. They're thinking about their ventilator-associated pneumonia that needs some subsequent treatment. I think on the checkbox before discharge is an EP consult for at least consideration of ICD. And for those without coronary disease, ICD needs to be placed.
All right, here's question number 4. So targeted temperature management at any dose, 33 degrees, 36 degrees, can induce shivering. Shivering is bad. Shivering is probably bad for the brain, and it may mitigate all of the effects of targeted temperature management if you have a lot of shivering. So some centers choose to paralyze patients prophylactically to reduce shivering, while others use an escalating stepwise approach that treats shivering only if it occurs. Is one strategy better than the other?
Many centers fear using paralytics on a routine basis for post-arrest patients. There's a general consensus, or at least a general notion, that long-term paralytics have adverse effects. You can have effects on muscle, long-term problems. Not to mention, some people are just uncomfortable with the notion of paralytics more generally. At our hospital, we've wrestled with this. We generally favor paralytics, and the reason why is we also believe that shivering is bad for a variety of reasons. And we also have a bit of humility about our ability to actually recognize and capture shivering. It's not always so easy to see. It requires someone to look for it. Shivering can sometimes be subtle in its clinical appearance. So the advantage of paralytics is it makes uniform standard care and takes that out of the equation. The other reason for paralytic use is a little bit unusual, but I'll walk you through this. If you do not paralyze a patient and the patient is inadequately sedated, the following situation can occur, and I've heard this many times in hospitals that, for whatever reason, don't use paralytics and have inadequately sedated a patient. The patient may start to move during cooling. And the question is, are they in there? Are they responsive? Do they not need TTM? But it's not clear. And in some cases, then TTM is halted. And then they realize, oops, we goofed. They sort of moved, but they aren't following commands. Now we need to reinstitute TTM. It makes a mess of therapy. And as we all know, a general rule of critical care medicine is if patients are stable, don't mess with them too much. Critically stable, that is to say. So we generally believe that paralytics are a good idea. And there are some studies that have suggested this as well. There's actually one randomized trial published somewhat recently, a small study, showing that paralytics were associated with a better outcome. Continuous paralytics, I should say, versus intermittent bolus paralytics. I think this question is still out there, though, and it's unlike the other questions you've asked me so far. I don't have as clear an answer, but in general, inclusion of paralytics for the short-term use following cardiac arrest seems to provide more consistent and even care for these patients.
So I think it's really interesting that you brought up the case of the patient that's inadequately sedated, because I think a lot of people would have problems with paralyzing a patient that is inadequately sedated. I think one of the things that comes up a lot is when we use neuromuscular blocking agents that we don't want to have a patient that is awake but can't move. And so, I think it's there. The flip side to that argument is whether paralytics actually increase your sedation dose in a way that's not needed, and might that impact like your neurologic outcome?
Yeah, that's a very valid point. And that's why I'm sort of less convincing when I make the case for paralytics. Certainly, we would not want people to be paralyzed and under-sedated. So no matter what you do, adequate sedation is really crucial in this patient population. These are not folks to keep lightly sedated for a variety of reasons. And indeed, there are some centers, the folks at Pittsburgh who are also very expert in this area, often make the case that sedatives in and of themselves can lessen shivering if you really sedate someone heavily. And that may very well be true depending on the sedation agents you use. So I think at the very least, patients definitely need to be very well sedated following cardiac arrest. And I tend to be in the camp that believes that paralytics are a useful adjunct as well.
Great. All right. So here's the last question. We know that mild therapeutic hypothermia can induce a coagulopathy, and it gets talked about a lot. But how much should we really worry about the coagulopathy that's associated with therapeutic hypothermia?
You're quite right in that the concern for bleeding has been much talked about with TTM. Indeed, that's probably one of the underlying concerns that led to the TTM trial, the dose-finding trial of 33 versus 36, with the notion that you might reduce some harm. You might reduce the bleeding risk at 36. It has been well known for a long time that cooling induces a mild coagulopathy, and so there was a good rationale for this. In the TTM trial, they found no difference in bleeding at 33 or 36. And in all of the studies that have looked at adverse effects of TTM more generally, the incidence of bleeding is very small. So for those neurologists in this audience, and I assume many are indeed neurologists, the bleeding risk of cooling is much less than TPA for stroke. Orders of magnitude less. So if you're comfortable with TPA for stroke, TTM should not frighten you. The studies that have been published seem to suggest a bleeding risk that is less than 5% of patients. Most have shown sort of 2 to 4%, and that's any bleeding. So in that percentage are folks who ooze from a central line site or have some pink tinge to their Foley output. So we're not talking major bleeding. The instance of major bleeding that requires intervention tends to be more around 1%. So one patient in 100 or less will get significant bleeding. So just to sort of highlight and accentuate this point, we have, and other places as well, have managed patients at 33 after receiving TPA for a massive pulmonary embolism, and they didn't have bleeding problems. We've given TPA to a number of patients who then subsequently went on to get cooled, and I have not once seen a significant bleed after TPA and then cooling. Now, that's just my experience, but I think this highlights the fact that the bleeding risk is talked about, and I think it's real, but minor and usually manageable.
Well, those were all the questions that I had. So these are answers to the 5 things that I wish I knew about post-arrest management. Ben, thank you so much for being on the Neurocritical Care Society podcast. It was really a pleasure to talk with you.
Well, thank you. And I look forward to hearing more from the Neurocritical Care Society. Your group is doing fantastic work. And I think cardiac arrest is a nice example of a disease that is actually relevant to many areas: heart, brain, cardiologists, internal medicine, emergency medicine. So it's a nice area for all of us to collaborate and learn together.
Outstanding. Thanks.
Thank you.
The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Romani Baloo, Mike Brogan, Josh Levine, Sarah Stern-Nezer, Benjamin Miller, Storeen Shepard, and Chris Zaman. The Neurocritical Care podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter at Neurocritical or Facebook. I'm Fawaz Al-Mufti, and thanks for listening.